At the end of last year's conference, I was talking with Dr. Blum about what it might take to, how shall I put this, to mainstream SOT a little bit more. I mean, you understand you're kind of like a cult within a bigger cult. SOT is a subgrouping, almost like an ethnicity within chiropractic, and there are many of such things. I've spent my whole career researching and working with all the named techniques. I'm myself a generic schmoo chiropractor. I practice a little bit of everything. But I respect all the major techniques, and as they say, I want them all to be as best as they can be. And that's why I entertain that knowing where L4 is would matter to you, whether you're SOT, Gonstead, AK, or Cooperstein technique. It would make no difference. But I did want to talk to you about what it might take to, I think, increase the visibility of SOT and maybe take it to places where it hasn't been before, to some degree. So this comes right off of a web page that I came across somehow at SOTO-USA. I came across this interesting web page where we see some of the mission statement, if you will, about SOT in terms of diagnosis and treatment. Not only somatic pain, but also disturbances in organ function. Of course, we know that. And then we see through the use of the CMRT procedures, we can normalize organ function and so forth. And then the third point, it really catches my attention. Like any other chiropractic technique, SOT also corrects abnormal spinal mechanics and any associated nerve problems. This can include back pain, headaches, dizziness, arm and leg pains. Again, in the spirit of what I said in the previous talk about cutting to the punchline first, here's the dilemma that you kind of run into. You know by now that most chiropractic patients are presenting with a pain complaint. It's at least 95% and it could very well be higher than that. My sense, though, when I look at SOT activity, this conference and also publications that emerge, is that most of the publications, I won't say 95%, but a very high percentage of them is about the treatment of systemic diseases and organs, glands and so forth, and not about that other 95%. So there's a fundamental mismatch over here between presenting complaints and what catches the attention of researchers and presenters in SOT, and that may be a little bit counterproductive. This is from the National Board of Chiropractic Examiners. They put out a big book about every 5 years or so. From the 2015 book, we see here why patients seek chiropractic care. And you can see that, as always, back pain is the main reason over here, coming in at, that's hard to read, where is it? 11% is mid-back, low back, 23% over here, neck 18%. But you got to get all the way up over there to find non-musculoskeletal 2.5%. Now you also get a slice over there that's called wellness, but even if you add together that plus non-NMS, you get to be a very small slice of that pie over there. Here's a study that was done back in 1999 by LeBoeuf, Cheryl Hawk, I should say, on, again, the reasons for which chiropractic patients seek care. Now, mind you, the way they did this study was they were specifically looking to recruit doctors who they knew in their community were looking for non-musculoskeletal patients. They were looking for chiropractors who were trying to find patients who had liver complaints and erectile dysfunction and you name it, all that kind of stuff. And in that very special non-random sample of chiropractors, even then, only 10.3% of the patients presented with anything other than musculoskeletal complaints. And you can get the list of what they have over there, but there's your 10.3 over there. And that is a non-representative group of chiropractors, again, looking for visceral problems. This study over here kind of repeats that. It was done at a chiropractic college clinic. And the percentage here is 5.8%. That's how you get that 95% of people with neuromuscular skeletal pain complaints. I did that same study over here. I couldn't find it when I was making these slides, but back in the early 90s, I was part of a team of doctors that did the same thing you're looking at here, but not in a chiropractic teaching college clinic, but in outpatient clinics, and we got the same number. This very similar to the practices in the college clinics. So here's what I think the way forward is. The way forward, I mean that the disconnect between all the buzz and publicity treating diseases, if you will, and the fact that chiropractic patients come in with all kinds of things. I'm assuming that when you open up your SOT office on Main Street, USA somewhere, the patients who come to see you are not that fundamentally different from the patients who see me. I always like to say that I see the patients of the people of Walmart.com are the people that I tend to see, just regular folk, not Jerry Rice and super athletes and all that, people that are coming in with cricks in their back and all that. Isn't it the same for you? I mean, you may be obviously looking for other things that the patient may not be aware of, but the reason why they're coming in can't be that much different from why they seek care at my office. Now, here's the way forward. This is a study that was done by Charlotte LeBoeuf-Ede, 1999. She should be a very important name to SOT practitioners because in the 1980s, she did a series of articles on taking a kind of orthopedic look at SOT procedures like the arm fossa test. They were inspirational to me in the work that I did with Dr. Blum, where we looked at the relationship of the arm fossa test with the sacroiliac motion palpation test known as Gillet. LeBoeuf-Ede kind of blazed the trail. But here she is working in another area, and here's what happened. She looked at, she put together data from many practices. This is called practice-based research. These are not professional researchers. They're people that generously opened up their offices to be seen as sources of data. And the question was, when people came in with musculoskeletal complaints and you treated them for that, how many of them reported improvement in something unrelated to really why they sought care? You're familiar with that. Dr. Blum mentioned that in his introductory comments over here. And we can see that in about 1/4 of the cases, people with musculoskeletal complaints reported improvement in something that wasn't musculoskeletal. And leading the way over there are respiratory conditions, digestive conditions, circulatory conditions, and vision disturbances. Those are the main 4 things that change when people seek care for musculoskeletal but report some kind of system or organ system improvement. That study was repeated much more recently in 2005. And the only thing they did different this time is that they drew data from different countries and different continents. And the exact same percentages were pretty much achieved. So we have a confirmation from thousands of patients seen in dozens, if not hundreds of chiropractic practices that these things are not unusual. They are actually the norm, that people show improvement in things for which they didn't seek care. So what I'm suggesting, where this is leading, is that SOT doctors might want to repeat that kind of study and show that doing what they do on a daily basis, they get improvements in these things. All right, so these are the kind of outcome measures that have been used in manual therapy outcomes research. As you can see, I'm not going to read that to you because you're all very good readers, and I have slides coming up for each one of those items over there. Biomechanical performance measures, these are the usual suspects: range of motion, motion palpation findings, and so forth. I want to direct your attention to the bottom in particular. You should all be aware of the work of Robin McKenzie, the physical therapist who revolutionized his profession, passed away about 1.5 years approximately ago. But again, after revolutionizing practice, he did a lot of practice-based research, not he specifically, but people practicing his methods did. And I was inspired by McKenzie's work on provocation listings, I would call them, to study blocking in the same way that he studied the McKenzie assessment procedure. And I was able to show that when people are blocked, what we'll say is the right way, you get a better outcome than when you block people the wrong way. That may be a big duh moment to SOT practitioners, but honestly, until you do a study like that, you really don't know if the direction in which you place the blocks under somebody makes a difference or not. You can assume that and say that you see that all day long, that it makes a difference, but there's a big difference between anecdote and doing a study that shows that. So I was inspired by McKenzie to repeat that using blocks and got a very nice outcome, thank you. These are some neurological exam findings that have been used to document improvements in patients. Likewise, physical functioning, parameters, jumping and providing child care, and the amount of time students can engage in what we call butt time at my college, just sitting down 35 hours a week. And these are pain scales over here. You're familiar with functional disability and pain scales over here. You all know about Oswestry for the low back, Roland Morris for the neck. I just want to make sure you know about the functional rating index that was devised and published by my friend Ron Fees over here. This is the only scale you'll ever need, keeping around in your office if you were to get involved in this one. This is good for the neck, for the low back, thoracic spine, headache. Doesn't matter what the complaint is, this is the form for all conditions. This is the functional rating index validated in a major journal. autonomic nervous system, but all the doctors here know this. These are the functions of the autonomic nervous system. These are the things that SOT doctors like to look at, in addition, of course, to all these neuromusculoskeletal parameters. I want to give you a couple of examples of people that changed the professional standing and the popularity, the amount of patients that they're seeing for their technique. We'll start out with Cox, flexion distraction technique. What's a guy got to do to make his technique mainstream, taught as an elective at every college, used in a million different studies, seen as the gold standard for technique research? Well, how about this? How about publishing an article called Clinical Outcomes of 1,000 Cases? Now, Cox didn't see 1,000 people here, but he has a lot of people who are certified in his method, just like you have a lot of people certified in SOT. Notice the coincidence over here. And so Cox enlisted his colleagues to simply do, I say simply, but it is kind of an imposition. He had them recording the patients who came in terms of what their complaints were, what diagnosis he came to, how he treated them, and then what the outcomes were as measured by standard outcome measures. And then he did that for 1,000 consecutive cases. Consecutive means the cases were not cherry-picked. People love to write about success stories. The person who was blocked and had autism go away. The person who was blocked and had, I don't know, HIV-related T-cell depletion reverse. We know these things happen. No one writes a case report of the person who felt pretty good, got screened by an SOT doctor, given some prophylactic care, and then got Hodgkin's disease a week later. I mean, nobody blames SOT for causing the Hodgkin's disease, but people get the credit for successfully resolving things in fluctuating conditions. So what you got to do is not cherry pick cases. That's the lowly case report is lowly for a reason. It's cherry picked always. We always kind of brag about our successes. But when you report on 1,000 people that came in, treatment successes and treatment failures, then you got something to work with. Now, when I read Cox, I never fully understand exactly what he measured and all that. You have to study his articles. You can't just read them. But I get the idea that he helped most people that came in, and that most of the people were pretty happy with the care. I think the bottom of the slide is kind of chopped off over here, but that's okay. And so here's a typical reporting of the data that he gathered over here. Typical patients seen for 29 days, 12 treatments. Only slightly more than the frequency visits that were reported by the Gallup organization in the poll that was just published. How satisfied are patients with Cox technique outcomes? Well, how about 30% quite a bit and 52% very much? So you have over 80% of the patients quite thrilled with their care, who will keep appointments, refer the practice to other people, and so forth. But you gotta gather these kind of data. That's just it, to mainstream a technique. Biomechanical outcomes, mainstreamed. Another practitioner, I just mentioned that Mackenzie passed away pretty recently. His fundamental principle is that if you want to judge your success in treating a case of back and leg pain, the question is how distal is the leg pain? Anything you're doing that makes the pain more proximal means you're on the right track, and anything that makes it more distal, you're going the wrong way. He passed away recently. So here's one of my favorite studies of all time. Again, multiple doctors were enlisted for this practice, all certified, I suppose, in the Mackenzie assessment procedures. A very busy slide, and I'm almost out of time. But they proved here that using they found that when people were randomly assigned to the right Mackenzie procedure, they got a better clinical outcome than when they were assigned to the wrong Mackenzie procedure. But even the wrong one got an outcome that was at least as good as nothing. How about that one? We have it made in manual therapy. If you do the right thing, you get a better outcome than when you do the wrong thing. If you do the wrong thing, it's not that much worse than nothing. In fact, it may not be worse than nothing. These are the outcome measures that he used, better in every case. This is the hierarchy of evidence. When you're thinking about what you got to do to put SOT on the map, realistically, you can't get there, right? You can't get to the top here, the randomized trials. You're going to have to be somewhere in the middle of this pyramid. My inner economist got thinking about indifference curves and all that. Don't ask, I don't have time to explain that. If another presenter doesn't show up, I'll give you an economics lecture and how you optimize the mix of rigorous research and practice-based research. Economics. Practice-based research, I've already given you the rationale. Cox is the best example. Getting patients, describing what you did and what the outcomes were. Here are some of the challenges. You need infrastructure. You need clinicians who could somehow find extra time to do extra things. Has to be funded, and clinicians are afraid of being co-opted all the time. They're afraid that if they make their research, if they do research, somehow it takes away the magic of chiropractic. These are some of the questions. What's your question? What's already known? Who would be the people in your study? What would it measure? How would you collect the data? Are there resources for that? And is it worth doing? So in closing here, you can read these slides on your own. I want to applaud SOT, which from the beginning acknowledged that they treat conditions. Chiropractors spend most of the 20th and on into the 21st century saying, what, are we condition-based, or are we finding objective indicators of the vertebral subluxation complex and reducing them? Well, SOT, at a time when other people were engaged in that, what I regard as a philosophical dodge, was involved in very explicitly stating, yes, we treat conditions, and you treat them with CMRTs and other methods as well. And so now that that first stumbling block has been overcome, you're not afraid to acknowledge that you treat conditions, never have been. The only question is what conditions, and I would recommend, are you saying I'm a quack? That you take on musculoskeletal conditions. Thank you very much.
Were these studies done standing when you were, relative to palpation and X-ray? Were the X-rays done standing? Were the X-rays done lying down, or were the palpations done in either position, or were they correlated in any manner?
It was all over the map. And so when I gathered the data from all those studies, I recorded which ones were done standing, which one were done recumbent. Some were prone, some were supine. They're all over the map. Not only that, but different technologies we use, ultrasound, MRI, plain X-ray. And then likewise for the palpation, some of the patients were palpated on a gurney by non-chiropractic practitioners. Some were palpated by others in a seated position. So it's all over the map. And that's one reason, by the way, that when you add the data together, you see some differences in the average location and also in the spread, the standard deviation of those differences. There are big differences in the outcomes of those studies, so you have to add together a lot of them to kind of cancel out the differences and wind up with an average.
If it doesn't, isn't it apples to apples here? So if you're judging the difference, it should be both of them should be done in one position.
Yeah, well, in some cases, in the same research study, they recorded both the radiographic location and the palpatory findings, so we do have some of that. Yeah, some of the studies were done uniformly with the palpation, and the imaging were done the same way. In other cases, there was an imaging study without palpation, although I must say all the palpation studies did have a reference standard, including imaging. There were more radiology studies than palpation studies, like about 15 compared with about 9. You don't look satisfied, but those are the data.
What's that?
You don't look happy, but those are the data.
No, it's not that I don't look happy. It's just that, if the qualifying question here on this study is that there's a difference between what is real and what is apparently real to some chiropractors, then in order to determine that, the steps you take should be very specific. So you're judging the differences between what is real and what is not real.
Well, in the real world, sometimes you have differences of opinion and different outcomes, but you have to go with the consensus of the data. And there's no question that the consensus of data is that the imaging location is lower than the palpatory location. And that's why people palpating always wind up a bone higher than they want it to be. That's how we got here.
Okay, just one other question. What's your definition of a successful outcome, the study for practice-based?
Yeah, I'm pretty unapologetic about being in the pain reduction business. So I have a pain clinic. Most of the patients come to me because something's hurting, and I'm very happy when they have less pain. I'm also very happy when they have better function. The tendency in modern research is to emphasize functional improvement more than pain reduction, and I'm in that boat too. So I'm not only looking at pain outcomes, but also at the ability of patients to do what they want to do, whether that be sports, child care, you name it.
Are you willing to help us with the practice-based study?
Yeah, you kind of overstated things in your introduction. I was horrified. to hear
have big hope.
I heard Dr. Blum say that I was starting a network, and nothing could be further from the truth. I will tell you this. I have done one. I did that once, working with my colleague, Dr. Hainline, and the good news is he did most of the work.
Excellent.
We studied acute neck pain. Acute neck pain is hard to study. It's just hard for various reasons. So we depended on doctors to gather data for us in just the way that I was describing, and that took a year and a half and a lot of resources, and we got about 100 patients in that study, and Mike did most of the work. So I kind of have experience personally of doing that kind of thing, but I myself probably wouldn't be the person to do it. But to do practice-based research, you almost certainly have to partner up with an institution like my own. I'm with Palmer, and I'm quite sure Palmer would be happy. You know, would have to go through channels and be approved by the Institutional Review Board and all that, but probably somebody at Palmer would be happy to collaborate, and I would be a liaison at least, you know. But whether I would be an investigator, that's a whole other story. I got my hands pretty filled with things, but you know, I'm not just trying to drum up business or a study or anything. I just want, you know, I would love to know when all is said and done, who comes into SOT practices, what their complaints are, what you did, what happened to the pain, what happened to the functional improvement, and not just, like I was using examples before, autism went away or something like, you know, I want to know about what happens to the other 95%.
But so that would be a good idea. If we
Yeah, I'm just curious. I've always been a fellow traveler, as you know, of SOT.
So if we could.
Dr. Hightower was my teacher a million years ago. Is he in the room? Where did he go? Yeah, Dr. Hightower was teaching at my college in Life College Weston in the 1980s.
You state that many of the case reports that SOT doctors are doing relate to visceral problems or more esoteric problems rather than straight skeletal problems, and that they're kind of outliers. My question is, isn't that another reason why we should be doing those things as opposed to focusing more on skeletal problems? Although, understandably, if they're simple and easy to do, we should publish those. But in order to preserve or to create an environment where more research is done into visceral problems, doesn't it behoove us to do these kind of reports?
Well, to the extent I could hear you, I think you were saying that you may want to emphasize treating the non-musculoskeletal conditions, right? Because so much other work has been done on
more of those reports so that they are more included in the chiropractic.
Yeah, the proposal that I have in mind here doesn't require you to change in the slightest what you're already doing, other than report what you're doing. In other words, I wasn't advocating that SOT doctors start seeking other kinds of patients. I would be pleased if they did exactly what they've been doing, but just report to the rest of us what the outcomes were for complaints, not only for diseases, but also for mechanical problems that people have, like your talk, by the way.